So I'd like to just start with a land acknowledgement. I acknowledge the land and waters. UVM is on land that has been a meeting and exchange place for Indigenous peoples for thousands of years. And UVM honors and respects these people, particularly the Abenaki, as the traditional caretakers of the lands and waters where we are today. So we'd just like to welcome you. This event is made possible by a grant from the Patient-Centered Outcomes Research Institute, or PCORI, an engagement award that was awarded to a group of researchers and stakeholders here at the University of Vermont. So that is who has supported this work and this gathering today. So this work is mostly spearheaded, and this gathering is mostly spearheaded by a group of people belonging to the UVM Autism Collaborative, a group of autistic and non-autistic family members, caregivers, researchers, clinicians, and autistic adults. And we're all working together to improve the quality of life for autistic people and their family. So just some housekeeping. For people who are on Zoom, you can have your video on or off and a picture on or off, whatever you feel comfortable with. You're welcome to share your pronouns. That is optional, so you don't have to. But we will just let you know that the Zoom meeting is being recorded, and we're also recording. I think there's a camera in this room too, so this room is being recorded. There will be somebody taking photographs and floating around doing that. If you prefer not to have your photograph taken, at the check-in desk, I think there was a little red sticker that you can put on your name tag if you would prefer not to have your photograph taken. So the photographer would then see that sticker and not photograph you or remove you from any photos afterwards. So if you don't have a sticker and you would like one, just please go back up to the registration desk at the top of the stairs and you can grab one. We have a couple of different spaces set up here. So the main presentations will be in this room, in the adjoining room over here, which can be accessed by this open door on my right, everybody else's left probably. And there's another door over here by this table of food, which is closed right now, but can also be used to access that room. That is an art and activity room, so just kind of a place to chill out, take some space. And there's also a designated quiet space, a smaller room, which if you go out this main entrance here from this large room, it's the first door on the left, I believe, a smaller room where you can take a quiet moment if you need. And other just general, feel free to just get up and move around if you need to, go get food in the middle of a talk, whatever you need to do. And all forms of communication are okay. If you are on Zoom, you are welcome to type your comments into the Zoom chat box. You can raise your real or your virtual Zoom hand. We will have a facilitator on Zoom who will be monitoring the chat and watching for hands. And so please do wait for the facilitator to invite you to speak if you'd like to make a comment. And safety comes first. We want to be sure to welcome all identities. This is a place where we hope everyone feels safe. So we acknowledge and celebrate all brain differences, all gender identities, all sexual orientations, all races, disabilities, ethnic backgrounds, and any other identity that you hold. Everything and everyone are welcome here. And just a quick note on autism and language, is that various people in the room might prefer various ways of identifying themselves. Some prefer identity-first language, like an autistic person. Some prefer a person-first language, like a person on the spectrum. And we respect how a person chooses to identify. So please feel safe and open to sharing however you choose to identify. And at this point, I'm going to pass it over to Lillian Savard, who is going to walk us through some of the projects that we ran as part of the PCORI grant. Thank you.
Disclosure. The opinions presented during the conference are those of individuals presenting their work. UVM or the UVM Autism Collaborative does not endorse the work or opinions or of any individual presenter.
Hi, everybody. I'm so excited to see many of you in person who I usually see on Zoom. So the first thing I want to do is just give you an overview of what we've been doing the past 2 years thanks to 2 awards from the Patient-Centered Outcomes Research Institute, or PCORI. So it's going to be really, really brief, but then we're going to have a panel discussion that Dr. Prelak here is going to facilitate, and you're going to hear more about it, and we can have some of a kind of a discussion about it. So one of our awards was to build capacity for autism research with community members. And we had 2 phases in that project. The first phase was, let me just change slide. Okay, so for the first phase, we had 2 focus groups type of meetings. The first set, like people who were on the autism spectrum met together, non-autistic people met together, and we also had a significant number of people who were both autistic and parents. So they met together and they just loved having that shared connection of having these dual identities. And we asked them what would make it safe for them to be part of a research team. What did we need to do? So it was really nice. Michael is going to present a poster later today. You can ask him like some of his feedback and experience with that. But we then used what everybody shared. Our whole team kind of looked at the transcript from those focus groups, and we came up with themes, like what were the big messages. And I'm sharing here like the 4 big messages. And under each of them, there were like more detailed stuff that they wanted us to do. So the first thing had to do with having a welcoming and inclusive culture. The other one was that the research, whatever people were going to be involved in, had to make a real-life impact. They also wanted the autistic viewpoint, like the people with lived experience, to be at the center of the discussion. And that was a little surprising to our autistic participants that actually non-autistic parents were so clear and strong about it. They came to that project because they wanted to hear what they needed to learn from autistic people in order to support their autistic children and young adults. And the last big message was that accessibility was like critical, and that included having many options for participating and all the other accessibility practices that are used with other people with disabilities. And then we moved to the phase 2. Oh boy. So for the phase 2, we were tasked to create 2 training programs. So our funder told us, okay, we'll give you the money if you do this kind of additional training to support what we already offer, which we told them after consulting people that are autistic, and even non-autistic researchers felt that their training was just too much and not accessible. So they said, okay, like do one that people will go through. So we worked on that, and we also asked people what they wanted, and they said, well, if we're going to do that research with non-autistic people, here are the things, like those 4 messages, right? So we built a second training based on those 4 messages, and we're in the midst of putting the final touch to it. So that was the phase 2. So remember I told you we had 2 PCORI award. So the other one, so that's what our training are kind of looking like. Okay, that's the website, and then there's many options on how you want to access it, like clicking through it, a video, or downloading a PDF. Okay, so that's the second project that we did. When we wrote our awards, we said, well, it's nice to talk about maybe doing research together, but like, what research? So we wrote the second award like specifically so we could start talking about a topic that was bringing everybody together. So when we talk about transition from pediatric to adult healthcare, this really like met everybody's needs. We were able to talk about accessibility, about like the needs of parents and families. So it was an excellent project to actually get a lot of sparks and new projects going. We have a website that has like all of our findings. I'm not sure if yeah, so that's the website. And if you go on the UVM Autism Collaborative website, you have the link to both projects. So all you have to remember is the go.uvm.edu/autism. That's going to bring you to the Autism Collaborative main page, and both project links are there. So basically, our healthcare transition project, people told us that these 8 things were the most important research topics that they wanted us to address. So trainings for providers, and then we already have a few projects, starting on that. Accessibility of healthcare. Dr. Hauser at All Brains Belong is the specialist for that, and you'll hear from her today. Individualized transition planning and support. We started working with VCHIP trying to address that. Starting early to prepare and empower autistic children for adulthood. We have another project, especially on gender diversity and sexual health, which was a big thing under the education that needed to happen. And then inclusion in communities of interests, building trust with healthcare providers, and like changes to the health system supports. Okay, so we're gonna have this panel discussion. We're going to invite some of our team members who worked on the project to answer some of the questions that Dr. Preluck is going to have on what we learned through doing all of that together. So I'm going to invite Emily Coder, who you met earlier. Zeph is going to join us on Zoom. So I think we're going to be able to just have Zeph on the big screen maybe, and stop sharing the slides. And who else? Jen. Jen is here. Will you join us for the panel, Jen? Okay, Jen is the co-chair of the Autism Collaborative. She's a parent of 2 autistic sons, and she's just been a rock star for quite a few years, keeping us going with all of our project. And Michael, sorry, I'm trying to keep my ideas straight. And Michael is an autistic licensed social worker who is also like a researcher and very involved with all of the Autism Collaborative activities. So please join us here if you don't mind, and I'm gonna pass it to Dr. Preluck.
Good afternoon, everyone. So glad you could join us. I'm Patty Prelock, and I had the privilege of working with these individuals and many in the audience to support our 2 projects. And I have to give a huge shout out to Lillian, who has really been a leader in both of these projects, and we would not have been able to do them if it wasn't for her. So I think she deserves a round of applause. Zeph, thanks so much for joining us online. So I have about 4 questions for our participants, and I know Lillian introduced them, but when you answer the first question, if you would like to say a little bit more about yourself, that would be great. So every single one of these individuals have been involved in both projects that Lillian described, the Healthcare Transition Project and the Research Project. And I would like to start by asking each of you, what did you learn about the ways to actually engage in research? And who would like to start? Jen, do you want to try? Okay.
And I apologize for being late. We had a medical event with my older son. We've been dealing with some seizures, which he had one when he was little, but we've had a few within a short time frame, so it's a little scary, but kind of part of being a mom of kids with autism. So we live in Heinsberg, which is within Chittenden County, and I have 2 boys. I have a almost 21-year-old and then a 13-year-old, both on the autism spectrum. I would say with my older son, definitely higher support needs. My younger is kind of still higher support needs, but not quite as, I think, at the severity level of my older son. I've learned so much. A little background, I grew up with a pediatrician as a father, and kind of have a background hearing about medical things, and just felt it was really important for us to be involved in research to whatever extent we can. I had actually been involved in some UVM research projects before getting involved with the collaborative. And it's been, just the connections with the researchers at UVM has been such a positive. Learning how, engaging in discussions. So my boys are, have higher support needs. And so, truthfully, it's been, we've had, varied experiences with being involved in studies. Some studies, have been successful. Some of the studies we've tried to do, they're just not able to kind of cooperate or engage with. There was one where they needed, my younger son needed to be in an MRI, and Patty was amazing. She actually came, to the MRI room with us and was there to support Alex, and we have a picture of his brain on our fridge today. He's so proud of that picture, but I think we just couldn't get him to lie still long enough to really, I think, get the picture that we needed to get. So just working, kind of brainstorming with researchers, ways to be able to engage individuals with higher support needs. Learning the process of research. I have a bachelor's degree in sociology, but never really have been involved in research studies like this. So one of the things I really enjoyed was learning how to do coding of data. And, that was a really interesting process. And, I would definitely be interested in doing some more of that. So, I'm grateful, thankful for these experiences, for sure.
We were so happy to have Jen's perspective, and I've known her for a long time and her wonderful family. And I think having a parent perspective on what research needs are important, and as her sons are going through transition to our healthcare transition project was a really important one, because she allowed us then to practice how we might impact the changes that our autistic population and community providers said they needed. And Jen and her family have allowed us to work with providers to see if we could do better, especially for young people with high needs. Zeph, why don't we go to you next and tell us a little bit about what you learned. And Zeph's been also an incredible contributor to this project in so many ways. Go ahead, Zeph.
Sorry, I was unmuted. Thank you for your kind words, Patty. My name is Zeph. I'm 58 years old. I was self-diagnosed with autism probably somewhere in my late 40s, but it would take until I was 52 or 53 to actually get a formal diagnosis for it. When I was in college studying family social services, which is a combined psychology and counseling kind of degree, I worked for the Public Opinion Laboratory at Northern Illinois University, and I started there as an interviewer on phones collecting data through telephone research, was promoted to shift supervisor and then assistant training supervisor. And what was really interesting is I got to learn how to actually write the surveys and test the surveys. And I've also done some work for market research companies where I was coding responses in addition to actually doing the data collection. So coming on to the PCORI grant teams, I learned more about the recruitment processes and what is required from places like the IRB in order to make sure that we're following the regulatory controls to make sure that the work is done in an ethical manner. I also did coding on the responses, which I've done before, but the coding that I did in the past was very simple compared to the complexity of the coding that we're doing with the data that we collected on these two projects, and then probably most of what I learned had to do with doing the qualitative analysis and thematic analysis and coming up with the big picture takeaways from the studies.
Thank you so much, Zeph, and I've learned so much from Zeph. One is she reminds us constantly of simple and plain language and how that's something that we say does not make a whole lot of sense. And Zeph's technology expertise is extraordinary, and their ability to organize and keep us on the straight and narrow is something I've appreciated, Zeph, so thank you so much. Let's go to Emily.
Yeah, my name is Emily Coder. I am a researcher at UVM. My background is in psychology and neuroscience, but I study language in autistic individuals. So I come from a research background, but I myself don't identify as autistic. I'm a parent, but I'm not a parent of autistic children, so I kind of have only one small slice of insight into this bigger picture, I feel like. What was the question? What have I learned? Yes.
Yeah,
So I think what I've learned most from this project is about the varying degrees in which you can involve people in the research process. I think researchers often think that it's too much work to involve people in the research process, in our case, autistic people in the research process, because there's all these, there's so much red tape about, how am I going to pay people? It's like there's a lot of barriers to overcome. And yes, there are, but that's so important because the insight that you can get and the quality of the resulting research is just so much higher when you do get input from everybody. And I've learned that the hard way a lot of times, and I've kind of done my own research and, thought, this is exactly how I should do it because I know best, I'm the researcher, right? And then I kind of give the task to people and they say, my brain can't handle it, or I think of it this way. I'm like, I didn't even think of it from that point of view, So getting that input beforehand or at every step along the way in the research process, I think is so beneficial to my own research. But I think it's also important to realize that it doesn't have to be all or nothing, right? It doesn't have to be input from everybody at every single step of the way if that's not feasible for a particular project or a particular research, or any amount of insight or of input or collaborative activity can be beneficial and really rewarding.
Thank you so much, Emily. And I think I've learned something similar, the value add of having an autistic research partner, but recognizing it doesn't have to be all or nothing, that there can be a part that an individual with autism feels comfortable with, and others who want to be full in, and others who don't. I also realized that what I think might be important to research might not be so important to the autistic population, and that has been a nuance in my thinking. And so before I think about another project, I'm always asking autistic partners, is this important to you from a larger framework? So that was a huge learning for me. Michael, how about you? What have you learned from being a part of these two projects?
Well, so, I was just thinking back a little to why I got into this. Ever since I was a kid, I really was interested in science and kind of loved science. But I love science from the point of view of, the sort of broader stories of science and the ideas and the exploration of that. And which is a very real part of what this field is. But on the day-to-day ground level, that's not what it looks like in most of the situations, especially when you're doing work with live human people, right? There's a lot of logistics to it. There's a lot of other sides to it. So, I really came into it with this curiosity about, I knew for a long time since I started learning about the diagnosis when I was a teenager that, you had science about autism, but it really was a mixture of stuff, and sometimes from perspectives that didn't really make sense as a person with direct experiences and things. And so there was this sort of gap between the experience of things and being able to share that and translate it to things, and what was being done in the science, which, you know, a lot of science is done in a way that works with the institutions that do it, because it's hard to survive like being a scientist and being innovative and going out of the mold at the same time. Like, it's a really resource tight world. And so I've sort of long wondered, like how do you really make the junction of these things work well? And been going to conferences sometimes and talking to researchers and like, well, is it possible to discuss like research from some of these other points of view, and how to maybe be a researcher from my perspective as an autistic person. And I noticed that like people were like, well, you know, I know this person out in Nebraska who you might want to talk to. And mind you, I'm talking to researchers at universities and stuff. And so that was a cue for me that this was a difficult thing for people, that they weren't really enthusiastic to think this would be an easy thing for like me as a person going into it in my situation. And I was probably more prepared than a lot of people would be for like a classic academic pathway to doing research. And you know, as I went along, I think they were correct at that sort of subtle assumption. So the other thing I noticed too is like researchers were, you know, like extolling the virtues of how sort of like technical companies were doing things to include autistic people in their work. I'm like, well, theoretically, research and technology aren't that far apart. And so the aptitudes for it could really go together. But the system, I think, is very hard. And so I did some work as a graduate student. That was difficult, and I really had a hard time working with the process that existed at the time with that, which was a normal research process. It's not like there was something that out of the mold with it, but I really found that as an opportunity to really start to see why things weren't working, like for me in that situation, and what that might entail about like how to do research differently. And the truth is it like it's very difficult to adapt it. It's very difficult to make a system that works for someone like me who has really variable levels of function, and to apply that in a research thing. So as I went along, after that didn't work out really well, I still kind of was like, well, so how do you fix the problem? And I ended up getting involved in this research kind of early on to sort of kind of hopefully push that along and make it sort of a positive thing. And I think in terms of what I've learned about research from that, I've learned a lot about the process, because partly like there are certain things in research that are very high expectations often in certain ways, and then there are certain things that people are used to taking shortcuts in too. And so like as a person on the autism spectrum, it's hard to tolerate shortcuts that will leave bad results, in my opinion, for people. And then as a person who, you know, actually does research and stuff in the situation, something has to give sometimes, right? So it's really been interesting to just sort of like see what that's like. And the truth is that I think it's research is interesting. There's a lot of work that can be done. It's been wonderful to work with this sort of somewhat rigorous qualitative approach to research, which is like underdeveloped, in my opinion, in society, and see some of the methods work and see a lot of different people being able to show up and participate, and then to see like what shortcuts we end up taking because of that, or what we have to sacrifice in the research based on how it's structured and funded to do it and stuff, and where you can be comfortable with those balances. So I would have loved to see some deeper exploration of some of the things that came up in the projects, but then we brought a lot to it by making some decisions to do things that focused, I think, more on really equitable integration of people. So it's complicated, but interesting.
Thank you so much for those insights. And I think one of the things all of us appreciated about having Michael on the team is he would always ask the question to help us think in a different way. And that was really useful as we were talking about where we want to go with our research, what we want to do with research projects, when you need to do shortcuts and when can you engage in the long game. So thank you for that. The next question, I want to start with Zeph and then Michael, and then maybe we'll ask Jen as well. And this is if you could identify 2 or 3 things that researchers should do to engage autistic partners in research. So what are 2 or 3 things that researchers should do to engage autistic partners? Zeph, we'll start with you.
I don't think I prepared for this one. So, right off the top of my head, excuse me, I just want to say that Lillian and I have worked really, really closely together, and she has been really great about accommodations. I get really anxious about trying to do particular things that have caused me trauma in the past or have the potential to spark trauma triggers for me, and she's been really sensitive about that. So that, I think, is one of the hot spots, if you will. The other thing is, and I think this may wind up being theme throughout the entire presentation today, but every autistic person is different, and so the relationship that Lillian and I have developed over the course of the last 2 years, in that she understands what I'm good at and what I'm not good at, and she feels comfortable asking me to engage on the things that I'm good at, and I'm really excited about that. But she also understands my reticence and gently pushes me along to try to break some of my barriers and boundaries and grow along the way. So I think that's my answer to that question.
Both really good answers, and a good reminder for researchers that it's important to make the appropriate accommodations based on the need of the autistic individual, and also to develop a relationship with them and know that each autistic individual that you work with is going to have a different style, different needs, different accommodations, and so relationships are so important. You did great on that question, Zeph. Michael, how about you? What would be 2 or 3 things you think we should do as researchers to engage autistic partners in research?
Well, okay, 2 or 3 things, that's good. So I think one of the first things to me is that if you're going to be a researcher and you haven't had a lot of contact with autistic people, have some contact with people, and have some balance of personal and contact and exploration of topics and subjects and stuff, maybe before it's even a formal research thing. And you have to be careful with the ethics of how to do that appropriately and in a healthy way. And at least I can't give very quick advice to that, but I think you keep that in mind. It's my first relationships, and I mean that in a casual sense of relationships with autistic people, other autistic people, were tricky and different and stuff. Interacting with people with different sort of social skills and ways of doing things and stuff, even though I have different ways of processing things, is different. And so even as an autistic person, it's not automatically simple or easy to really get it right. and have those positive relationships. And then the other thing with that piece is to be really, really careful and sensitive to the consequences of those relationships and how to definitely, I mean, it's important not to use things against people in those relationships too, and that can be hard because there's a lot of sense of dual relationship to this kind of work where we're being supportive to people and we have our own lives and we have our own needs. And so the second, but I think it's good not to throw the baby out with the bathwater with that. Secondly, to really be aware of the environment that you're in. And like if you're working in most researchers are working in either an academic institution or maybe government or a corporate environment, but there's not a lot of corporate research in this. So I think part of the other reason where, when I talk to researchers years and years ago from different places, and there's that sort of sense of ambivalence about doing research with autistic people is because I think people know that academics traditionally isn't accessible. And it's a really big part of the scheme of at least how sort of more intellectually active autistic people have challenges sort of transitioning out of childhood and into the workplace and that kind of thing. So there's already a sort of complex web of relationships that you're sort of implicitly part of if you're working for a university or if you're working at a hospital or whatever. The same is true of human service agencies and stuff too, in different ways. So to have some understanding of the types of privileges that go along with these things, the social statuses we experience, how we navigate those things. So, it's a slight side point, but I found that social skills in a given situation are very dependent on your social status in that situation. So if you're perceived as an authority, people treat you differently, have different expectations. We're often not really at the highest point of social status because of how our lives work out. And we have to work very hard within that to be seen well. And so to recognize that and have a good relationship with that, I think, is really helpful. And third is to understand that it takes time, and there's likely to be a lot of glitches in the process, and to be resilient to those, and to be resilient to those in a way that both helps you out as the researcher in that situation be successful and pull those projects, and to build in the time and stuff to your grants to really be able to deal with surprises or variances in what people are able to do or accomplish. And so people can have higher expectations going into things, but know that they won't always happen the way that you think.
Thanks so much, Michael. So 3 important lessons for me as a researcher is making sure that we're engaged in ethical practices as we're building relationships with autistic partners and the consequences of those. Making sure we understand the environment and how that is going to influence research. And then it takes time to really make it work and make it work in an important way. Jen, from a parent's perspective, is there anything that would encourage you to be engaged in research or discourage you from being engaged in research, and how might we do a better job with families of autistic children or adults?
First of all, I think sometimes parents are just overwhelmed. So I think that can be a big barrier. And, one of the things, an example, my younger son engaged or did we participated in a project that Lillian is currently doing, I think, a research project, and she just made it really easy for us. She was just very flexible. So I think having some flexibility in terms of, this was a project where we needed to be in a gym-like setting, and she gave a number of different options. She was willing to come to his school. We had an option at UVM, or we could, I think, travel to Montpelier. But it ended up that UVM worked out really well, and for Alex, it was actually, for both of us, it was fun. So I think just maybe having some flexibility. I'm kind of losing my train of thought with that.
I think flexibility is good. That's a good lesson for all researchers. Emily, is there anything you want to add from a researcher perspective that you've learned about the best way to engage a research partner?
I think the biggest piece of advice I would have from a researcher to an autistic research collaborator, if that's okay, can I shift the question a little, is kind of looping back to things that Michael has kind of touched on already about this balance between kind of wanting to go deeper on these different, these different avenues, but then also realizing that that's not always feasible. I think researchers are often tied in a lot of ways to, the institutional bureaucracy or the funding mechanisms requirements and things like that. And so if there's, in a collaboration, if you put forth an idea about, I think we should study this or we should do it this way, just being open to the idea that we might not always be able to do that, right? Just because, which is not to say that it's not a fabulous idea or, we want to do that in the future, but sometimes we do need to balance that kind of the needs of multiple different agencies and inputs with the feasibility, with, where it can go in the long term. So just kind of recognizing that and working in a collaborative way to kind of reach the best possible outcome for that particular project.
I think that's a really good message. It really suggests that in research, it has to go both ways for it to work. Both the researcher has to understand the unique needs and differences that an autistic partner brings, as well as the autistic partner understanding what the expectations are from our end. Lillian, how are we doing for time? Are we good?
So I know that Zeph has to leave
Okay.
right now. So Zeph, you can tell them to feel free to go on to their scheduled activity, and you can continue for another 5 minutes with our other.
Okay, another 5 minutes?
Yes, but Zeph can leave if they have to.
Okay. Zeph, thank you so much for participating. I know you cannot continue, but it's been great to have you as an autistic partner. Is there any last message you want to share with us?
No, thanks. I'll be back by 2:30.
Okay, great, great.
Thank you.
In the last 5 minutes, I would like to just ask you this question. All of us have been involved on the Healthcare Transition Project, which was a really an important one to me because I had heard from families and autistic teens and adults that there seems to be just a huge gap between going from pediatric care to adult primary care, and there's like no real connection. So I learned a lot in our healthcare transition project, and it has caused me to think about some changes, and I just would love to get from your perspective, is there one thing that you think, based on what we found, that we should change in healthcare transition for autistic adults or teens? I know there's probably 10 things that you could think of, but I'm going to tie you to just one or two. Jen, how about you?
Yeah, the timing of this project was perfect for me, or ideal. We're right in the thick of. I've got a son who's transitioning from. He's going to be 21, so we're transitioning from pediatric to adult care, and there are at least 10 probably. I think I think for us, in our recent experiences,
one thing that was key was having a person to reach out to. So I would say a care manager. To help coordinate things. We had I mentioned we've been having difficulties with seizures, and we got a call from the school, and, you know, my husband and I rushed over, and, you know, my son had a fairly scary seizure, and I reached out to the pediatric office, and they was told that he was no longer a patient there, and we're trying to transition, and so, you know, I started to panic, and then I took a deep breath, and I reached out to the care manager from both the pediatric office that we were currently supposed to be part of, and then the new office. And within an hour, they both got back to me, and they, you know, assured me that I was not alone in the process and that we were going to figure this out. So I think that, you know, if I had to choose one thing, you know, that just having someone in a situation like that where I was overwhelmed and I was, you know, concerned for my son, somebody that I could reach out to who I knew would help me and would you know, kind of figure things out, help me figure things out is huge.
And I think that's what we heard in our 56 stakeholders who were involved, that a care coordinator or manager for transition is huge. Emily, how about from your perspective?
That was going to be my answer. I would just second that. I think this project was really eye-opening for me because I felt so naive afterwards. Because again, I'm not autistic, and I don't. My kids aren't at transition age yet, so I haven't even gone through the pediatric to transition phase yet, except for myself. And I remember for myself how overwhelming it was just to, you know, healthcare do I sign up for, and what benefits do I don't know, you know. So I think a care coordinator would be helpful for anybody. But then I came away from this project just having so much respect for anyone navigating the healthcare field or the healthcare system rather with complex medical needs. Because it's just so much more complicated than anything I had ever gone through. So again, I felt really naive coming out of this project. And it just, it reinforced how valuable it would be to have somebody there who understood the whole thing and could work with you one-on-one and walk you through it.
Excellent. And Michael, I know you were involved, like me, with a lot of the focus groups, so you heard a lot from the community. What is one thing that you would like to see change in the healthcare field for autistic individuals?
Yeah, I think the big thing with the transition mostly ends up going to what the adult healthcare system is, because it's not necessarily that different when you turn 18 or move to a different place or that kind of thing, I think, in actuality. But in terms of the one sort of big takeaway, I think it comes a little bit down to what my advice was for researchers, which is to kind of know autistic people if you can, if you're a provider and working with autistic people. And that can, come in different forms. Certainly, I think it would be good to have more like people like myself sort of having a sort of consulting and advising role to people in these things, so that there can be some sort of sense of feedback and perspective that people can get in it. I'm just thinking of the sort of low demand things that could be done in the system that might make a real change quicker. Like ideally, like everyone would really have amazing backgrounds and everything and stuff that they do, but that's hard. I think someone in the system really needs to understand a person's care needs well and how it interacts with everyday life. So like part of that thing about knowing autistic people is at least understanding the just basic dynamics of anyone in dealing with the complex aspects of what it is to live with a disability, and then how does your practice impact that? How is like your choice to try a medication at a certain time go with the fact that maybe someone like for me, just simple, like I use ADHD medications, and I think my primary care person doesn't really understand very well what the impact of, say, not having them at a certain time is to my ability to sort of survive in the everyday world. So like that kind of thing, I think, goes a lot of the way. And like the other step with that too, I think really mixing science and really thinking of some more connection between research and everyday practice, so that people can go into some depth about understanding things that there aren't ready-made explanations for is also part of it.
Yeah, excellent. I think one of the big things we did here was being autism informed, and there aren't enough providers who are autism informed, and then that would then help you maybe change what your waiting room looks like or how you communicate with an autistic person, and also to give some education even at the high school level for the autistic person and family, how to advocate for their health needs so they actually take care of themselves and can say, this is what I need to be successful in your adult primary care office. Well, it's been wonderful to work with you all, and Zeph, who I think is going to join us again later over the last 2 years, and Lillian for her leadership, and a big thank you to all of you for participating today and for teaching me a whole lot and making me realize that every time I think I know something, I know less. So thank you very much, and thanks everyone for listening.
Okay, we're going to get started again. Welcome back, everybody. We're going to come and have a seat again. Our first speaker is Dr. Laura Lewis, and the title of her talk, I'll let her do a little bit of an introduction of herself, but the title of her talk is I Believe You, Understanding the Health Stories of Autistic Adults with Complex Health Needs.
Hi, everyone. I'm Laura Lewis. I use she, her pronouns, and I'm an associate professor at the University of Vermont. And I'm really excited to share a study that our team has been working on for quite a while with you today. So at first, I just want to acknowledge our research team. So Dr. Melissa Hauser, who you'll hear from later on today, was co-investigator on this study. And our co-researchers include Zeph, who you heard from earlier today, Sarah Knutson, Janelle Starr, and we had a lot of research support from Katie Paris and Lizzie Purat. We also received funding from the Autism Intervention Research Network on Physical Health and the AIRP Foundation. I also want to start with a content warning. So in this study, I'm going to be talking a lot about really difficult healthcare experiences that our participants had. So there will be some discussion of premature death, distress, medical trauma, and gaslighting that can be upsetting to hear about. So I do welcome you. If you need to step out, please feel free. Or if you need to mute this or turn off the audio if you're on Zoom, feel free to do that. So I want to start with some background why we actually conducted this study. So the average life expectancy of autistic people is 36 to 54 years. For context, this is 23 to 41 years shorter than the average life expectancy in the United States. And autistic adults are at increased risk for a multitude of health conditions compared to non-autistic adults. So these include, but are not limited to, heart disease, suicide, neurologic conditions, respiratory conditions, cancer, and more. And autistic folks are also at higher risk of having multiple conditions at the same time. So this leads to really complex health needs for a lot of autistic folks. And that is coupled with the fact that autistic individuals often have poor access to healthcare to prevent and manage these complex conditions. And we've seen a lot of research showing a lot of the reasons for that poor access, but studies time and time again are showing that it is difficult for autistic folks to receive healthcare. For those who can access care, we are also seeing time and time again that providers often don't know how to best care for autistic patients. So for example, in a large survey study of 922 adult healthcare providers, what they found in this study was that 30% of providers were unaware that they cared for any autistic adults. Most indicated that they didn't know signs someone might be autistic. Nearly a third reported that they didn't change their plan of care if they suspected that a patient was autistic. And 77% rated their knowledge and skills in providing care to autistic people as poor or fair. And that's just one study of many that continue to show us that when autistic people are able to access healthcare, it often isn't up to the standard that people need it to be. Anecdotally, this is coupled with evidence from our clinical partners, so particularly All Brains Belong and Dr. Mel Hauser's work in the clinical setting, reporting time and time again that patients tell us that when they are diagnosed with multiple conditions, it often leads to them feeling confused, isolated, and a sense of being broken. And this is reinforced in their healthcare encounters. So the purpose of this study was to understand how autistic adults make sense of their health in the context of multiple health conditions. So our long-term goal is to improve providers' understanding of autistic persons' bodies by providing a lens to zoom out and see these connected conditions as part of a larger system instead of looking at them as something to be managed in isolation. We're also trying to bridge that double empathy problem. So really understanding, recognizing, and valuing different ways that people perceive and experience the world, especially when they're coming from different neurotypes. So I'm going to talk a little bit about the method that we used for this particular study. So really foundational to this project was a participatory approach. So we had really authentic community involvement from the beginning ideas of this study. This was something that we talked a lot with our autistic community partners about the importance of before we got started. And our autistic community partners were co-researchers that were really involved in every step of this process along the way. So all research materials were developed together with our autistic partners. Our data, as we were collecting data, we were talking to those partners, helping to interpret the findings, doing a lot of that analysis work together, all the way through dissemination. So I will say that I am speaking, like, I think my words here are my own, but I certainly represent a lot of the ideas that we've talked about with our team when I'm presenting today. We had weekly meetings as a team to go over all of these findings. And I want to share with you just some of our ways that we recruited. So our recruitment happened mostly online. We went to different organization websites. We posted information there. We also were posted in a lot of different autism organization newsletters. We were on social media groups. And then we also mailed physical flyers to a lot of different autism organizations to have that physical presence as well. Our inclusion criteria were autistic adults, so this was age 18 and up, people who lived in the United States and had at least 3 or more health concerns, and those were really self-identified, so they didn't have to be something diagnosed by a provider. This could be something that somebody was concerned about related to their own health. Participants also received a $45 compensation for completing the study. Excuse me. The way that we collected data was really influenced by our community partners for this study. So we wanted to capture people's ability to tell stories in whatever way was comfortable to them. So we had 5 different ways that people could talk to us about their health experiences. We called this the multimodal data collection. So we had options for people if they lived in Vermont. They could meet us in person to do an interview. They could do a phone interview, an interview on Zoom. They could complete an online survey or a mail-in survey. So if somebody opted to do one of the surveys, we had a way for them to have follow-up questions that were individualized to them, and we would continue to have, send them a new survey. They would send back their responses. We'd send a new survey, and we'd get their responses until we felt that we really had a strong understanding of their full story. And for people who were in person, we continued that as a conversation or phone or virtual. Those were all audio recorded and then transcribed. So this was a 3-step process of data collection, and for the purposes of today, I'm going to focus on that 3rd step, really where we're trying to hear the story of someone's health journey. So we had a lot of instructions for people and a lot of different ways that they could give us this health story depending on which option they chose for their communication preferences. But I'm just going to highlight here that how we defined that health story to people. We said by this we mean the experiences that you've had as you have come to understand your own health. So we had options for really broad. If that was people's preference, we just said, tell us your health story. You can start wherever you'd like and finish wherever you would like. We also had prompts if people preferred that along the way. And if people were overwhelmed by sort of the big white space and the big conversation, big topic, we also had an option for people to ask for more specific and targeted questions where we had them fill out a health questionnaire, and then we took different concern through concern. We went one at a time and said, tell me this about this, now tell me about this, and they could walk through those concerns with us. We ended up analyzing 30 interviews using a method called narrative analysis. So I'm going to give a very brief overview of narrative analysis. To analyze these interviews, we used Burke's dramatistic pentad. So that's basically identifying 5 elements of story within different parts of somebody's health story. So we looked at scene, or the where and when. We looked at agent, or the who in the story. We looked at act, or what was happening. The agency, which was how it was happening. And the purpose, which was why it was happening. And for each of these elements, we sort of looked at them compared to each other to find areas of tension, or what we call trouble in this method, to try and identify areas that were sort of out of balance and driving factors for the conflicts that we were seeing in these stories. So I'm going to get into the results. I will tell you that we are still writing up our results, and there are a lot of them. I expect this will keep us busy for a pretty long time. But what I'm going to present on today is really the arc of people's stories. So typically when I share qualitative findings, I like to give a lot of quotes. In this case, with narrative analysis, we don't break up the quotes into short snippets. We look at full stories together. So for the sake of time today, I'm going to sort of summarize the story arc that we were seeing more than sharing participant quotes as our main way of sharing data. So the main area that we identified as being troubling for most of these participants was this disconnect between the act that was happening and the agency, or how it was happening. So all of our participants spent a significant part of the interview talking about their healthcare experiences. So we were pretty intentional about asking more broadly about health experiences and not specifically healthcare, but healthcare was where we ended up spending most of our time with participants because of the tensions that they experienced in that specific part of their health. Almost all participants characterized these experiences by a feeling that they weren't believed or taken seriously by their providers. So what we often saw here was that truth was placed in these so-called objective assessments rather than in patient experiences, and the resulting act was ineffective delivery of healthcare that didn't meet the patient's needs. So I'm going to just kind of walk through the story of what was happening for a lot of these people. So where this story began for a lot of people was their own awareness of what was happening with their body. And what people shared with us, that a lot of the time they weren't even aware that what they were having was an experience. They didn't have language to talk about it. They didn't have people who had a shared experience with them to understand what was happening in their bodies. Some people talked about thinking everyone felt this way, but simultaneously people felt really isolated and alone about what they were feeling in their bodies, and something that other people weren't talking about and that they couldn't even really articulate to people in their circles. People also talked about it being really difficult to trust their own experiences because of a lifetime of wider social and cultural beliefs that experiences like the one they were having weren't real or valid. So this was put in the context of people telling us about things that happened to them when they told their parents they got headaches as a kid, things that their teacher would tell them when they first started elementary school, and things that had happened to them in a doctor's office when they were kids, when they complained about something, and it was being written off as that they just didn't want to take that test, and that was what was happening. And so it was really compounded this childhood feeling that what I'm going through isn't real. If people reached the point where they became aware that I'm having something here that really needs attention and support, they often felt hesitant to seek healthcare. This did come from past experiences in many cases with healthcare that were really painful, were often traumatizing, were difficult. People told us some really upsetting stories of healthcare encounters that they had had, situations that were assault and abuse in many cases. They also had a lot of experiences where they questioned when to get that health care. So, for example, they were worried if they went too early that it would be dismissed because it hadn't yet reached a pinnacle of this was the amount of concern that we need to have yet. But what happened is a lot of these people ended up waiting until they were in crisis to actually seek health care, and then often were reprimanded by the provider that they didn't come in sooner. So if they were able to actually access healthcare and get that healthcare, a lot of people talked about having difficulty finding language to communicate their experience to the provider. So this was assuming that they were able to get in the door, get that appointment. They often had barriers to actually telling that story when they got in the office, many times because they had never heard anyone talk about the experience they were having before. So not having language for that experience because they just didn't have context for that. And then if they could find the language to describe their experience, A lot talked about it being difficult to communicate in the time and space of our healthcare system. So for example, a lot of people wrote down what was going on, and they brought it to a provider, and they were told by a provider that they didn't have time to read it, that we don't have time to talk about that today. You need to tell me, specifically what's going on. And so for that person, in that space, the social pressures of the time and being able to think of and articulate what they wanted to say was often really thoughtfully put together already, and then ignored in the context of a visit. People also talked about tailoring their explanation for fear that a provider might see them as crazy or disregard their experience. So I'm only going to tell a little bit of this because I'm afraid if I tell you too much that you're going to read into it and think that there's something else going on with me. So it was this constant trying to figure out how to get the provider to understand what was going on that was sort of just a difficult challenge for a lot of folks. In addition, a lot of people talked about masking and camouflaging as being a barrier. So they felt that providers often misinterpreted their body language or their facial expressions. So for example, if they came in and said they were in a lot of pain and their facial expression didn't match what that provider expected to see from somebody in a lot of pain, they felt that their experience wasn't believed. If they were able to effectively communicate with a provider, what they found was two things often happened. One was that their needs for information often surpassed the expectations that the provider had. So for example, people talked about providers brushing off their concerns and saying, well, I'm not really worried about that, and not giving any deeper explanation of why they're not worried about that or what they think is going on instead, but just saying, well, I'm not concerned, you don't need to worry about that. The other thing that happened is that a lot of providers' responses didn't align with participants' own understandings of their bodies. So for example, two major things that providers often leaned into were weight and mental health. That, well, this is related to your weight, and that's the problem here, or this is related to your mental health, and that's the problem here. And people felt that, I actually have been many different weights and I've still had this problem, or I've actually been getting really great mental health support and I feel like that area has been really well supported by a therapist, for example, but I'm still having this other problem that I need help with. And those things were often sort of ways that providers wrote off their experiences. People also talked about providers telling them their experiences didn't really make sense. One thing that I found really fascinating as a nurse looking at these stories was that people were often really looking for language for an experience that they didn't otherwise have language for. So they talked about going to medical textbooks and reading all that they could about something. And then when they got to the provider, they were using the language that they had available to them. But the way the provider often interpreted that was, well, that doesn't really add up. It doesn't work like that. It doesn't make sense the way you're telling it to me. And as a nurse, what I think was really fascinating about that was that people, they haven't gone to medical school. They haven't gone to nursing school. They're using the tools available to them to find the language. But because they're not maybe using that language the way the provider was taught that language looks, the provider dismissed the whole experience, that this isn't how that works. It's not that, and they would move on. We also saw a lot of people talk about lack of understanding of the holistic experience. And that often tests were coming back negative and care ended. So, we ran some tests, they were negative. It's not that, you're goodbye. That was the end of care, without actually supporting the person in any other way. If people felt that a provider took them seriously, they often still didn't have diagnostic labels that fit their understanding or treatment plans that supported these individuals' health. So they often received siloed care. There was a lot of gatekeeping of diagnoses happening where people said, the support that can come from just having a name for what I'm going through, I was deprived of because the provider said, well, it wasn't a perfect fit, so we're not going to give it a label, and they would move on. And for people that were really desperate for understanding their own bodies, this was difficult for them to not have a label. They often were also receiving treatments that were ineffective and often burdensome. For a lot of participants, they told a provider, I've already done that and it didn't work. And the provider would say, well, we have to start there, so do it again. Show me it doesn't work, and then we'll see, we'll go from there. And people felt like, well, when I did that treatment, it was really uncomfortable, or it was really expensive, or it was really difficult in my social circumstances. They often had physical side effects that were uncomfortable or painful. And providers really made them start from that 0 point every time again. And this left our participants feeling frustrated and then further judged for being frustrated. So they were sort of deemed bad patients because they had this reaction to the providers that was like, you've got to be kidding me, now we have to do this again. And the provider thought, well, here you go, getting all worked up. And the provider sort of wrote off their frustration and this added level of judgment on top of everything. A lot of participants were told if they really wanted help, they would do X, Y, or Z. And people ended up feeling coerced into accepting treatment plans that didn't align with their own understandings of their bodies. And they often felt judged on top of that. So our main takeaway from this was that people came in with one problem and they left with two. They left with the same problem they entered the system with, and in addition had the added stress of feeling dismissed, judged, invalidated, and questioning their own reality after their encounters in the healthcare system. A lot of people ended up opting out of the system altogether. People talked about becoming their own advocates. They talked about leaning into online communities for support, finding whatever they could from people online, saying, hey, try this, this worked for me, because they didn't feel that the healthcare system was a legitimate option for them anymore. And a lot ended up doing extensive amounts of research on their own. The transformative flipped script here that we did see from a few participants that tells us that better is possible is that in cases where people felt like their experiences were heard and understood and believed, even if the provider couldn't help them, understanding their holistic experiences and believing their lived experience supported their health. The best thing it did was at least remove the psychological burden of feeling like their experiences were invalid and that they defied logic. So at least taking off that psychological burden that they were carrying was extremely supportive, even if no physical intervention could be possible for them. So I have some key takeaways for providers just to talk about. And the first and most important would be that explicit naming that you believe a patient and really telling them that you're there with them, you believe them, and that you are curious about what's going on in their bodies and willing to work with them to try and figure that out together. So even if we can't provide answers, believing someone can be powerful and healing. Explaining why you're not concerned if you're not concerned. So really giving that added layer of information to the participant. What we often saw from our participants, I know from a provider end, that when we tell somebody don't worry, it's often meant in a way that's supposed to be reassuring, like, oh, I'm not worried, don't worry, nothing's wrong. And the way patients perceived that was actually that it was very uncaring. So it gave the opposite message that the provider was meaning to send for a lot of these folks. Also recognizing that patients are using the language and tools available for them, and making space to hear language that might not match your understanding of reality, that there can be experiences different from your own, and that can be just as real and valid as your own experience. So really hearing what is meant and intended behind that language is something I think providers need to be willing to listen to. And recognizing and unpacking biases, particularly related to mental health and obesity, and weight, I would say in general. Question how much you're leaning on this as like the answer to what is happening with somebody's body, and really hearing out that person's experience in a way that goes beyond initial biases. And then I think also very important in this is taking patient experience as objective data. That a lot of these participants talked about the time and energy that went into questioning whether what they went through was real, took up the bulk of the visit. So instead of actually hearing what was going on with the patient and moving into trying to figure out how we can support the patient, most of the visit was spent sort of questioning like proof of what the patient was saying. People even talked about needing to have a second person with them in the appointment to sort of validate what they were saying was true. So really understanding that tests are one thing, but tests can be flawed, and that patient experience needs to be taken at face value. Key takeaways for patients, I'm not going to talk as much about today, but I just want to point out we'll have a whole presentation from Dr. Malhauser coming up. But one way that we can start to bridge this double empathy problem is some of the tools that Dr. Hauser and All Brains Belong are working on. they have some tools for patients to bring to providers that can help sort of in the way providers are cultured to seeing language about complex health needs, can help inform inform providers from another provider that's been vetted with a lot of providers in a way that they may be more open to hearing than a patient just going in and reporting those experiences on their own. So QR code to Dr. Hauser's resources here, and we will hear more about that later on today. And I don't know if we have time for questions or... Sounds good. If anyone has any questions or if there are any on Zoom. Yeah.
Second.
Thanks. Hi, I'm Phyllis. So my question was, did you gain a sense from the research or from the folks who participated what they needed to hear, like some specific suggestions on you come into a space, you're with a healthcare provider, what is the step 1, 2, and 3 that you would need to feel comfortable in that particular setting?
That's a great question, and I think the answer is a lot bigger than a 1, 2, and 3, perhaps, because I think a lot of this is creating a culture of inclusivity and safety beyond just the words that we can say. Because if you walk in and tell a patient, "I believe you," but you don't, those words fall flat, and that patient can tell. So I think having just a script to follow, if we're not changing the underlying feelings that are behind that script, there's only so far that that's going to get you, and in fact may undermine your trust with that patient. I think patients really need to hear from this study that we genuinely are curious about what's going on with them, that our goal is to support them, and that we believe them. And that has to come from a place that patients can really feel that and tell that. And I think it also needs to be made explicit. Not sure that answers your question. I think we're working on developing a list of really practical strategies that providers can use. Yeah.
I just wanted to share that everything that you said is exactly what I've experienced, and really interested in what you just said about, people can tell with regard to the double empathy problem. My personal experience is that I'm so sensitive. I will shut down. I can tell if, like you said, if someone says, "I believe you," it's a very difficult experience to go through that. And then, the frustration side of it is really challenging because, I've personally been fired by a number of providers because I get legitimately frustrated with them for not helping me. And then I get, I'm on this wheel where I can't get the help that I need. So I just want to suggest a solution, which is I feel like this study should just be mailed to every doctor office in the state of Vermont. Maybe in a brochure, something that won't take them that long to read. But I'm just saying that very urgently, we need help, we're really suffering. And I understand that you understand our suffering, and that's good, to have a study that, shows that you understand our suffering, but it needs to, we need some results, we need something to change. And, I guess that would be my question then is, what do you think is the mechanism for change? How is this information going to get out to providers so that we can get the help that we need? Because myself personally, I have medical issues that I've had for over a decade that still haven't been addressed. And then when I say, "Oh, look, I had this report that said I needed this, study to be done 15 years ago, no one ever acted on it." And they're like, "Well, you need to go back and, see another doctor and then see if they'll order that scan," or whatever the thing is. So anyway, what steps are planned for this research, and how do you think this research can be used to help?
Great question. And I need to start by just saying that I'm so sorry that that's been your experience. I think we deserve better from our healthcare systems and our providers. I think the providers are often thwarted by the healthcare system as well. And I don't think this is an issue of just uncaring people providing care in most cases. I think it's providers who are set up for failure by the way our system is operating. So some starting steps, we are still working on developing sort of a practical list of takeaways for both patients and providers from this study of things that you can do in an individual healthcare encounter to help bridge the double empathy problem. And our immediate plan is to try and publish this in a journal that's not targeted towards autistic providers or providers who are primarily interested in autism, but to target an audience of providers who are just providing primary care, who are seeing patients more regularly. And then I think All Brains Belong is doing a lot of great work locally on trying to change the way that healthcare can look for a lot of folks. So I think that's a great starting model that I think we need to start looking closer at and promoting how we can build other practices that are doing similar things. I think one of the other things that you'll probably hear some from Dr. Hauser later is the importance of social connection for a lot of people who are going through these experiences as well, to connect with other people who have also experienced these really harmful health interactions and health experiences with their bodies, and starting to build some of that psychological healing in addition to the work that we need to do to start coming up with better answers for understanding how to support health. I think we're in the early steps of actually taking this and making a difference with it, but I'm hopeful that we can use it to launch some bigger studies to make bigger change. I think I've taken up more than my time here, so. Super.
Sarah, do you want to go ahead?
Oh, thank you so much. So sorry. Thank you so much. Fabulous presentation, and just it was really amazing to just sort of be a part of the research project. Just to go to the first question that someone asked, I think the thing that for me, and I don't know if this was for other participants in the study, but for me, what I'm really looking for is I might not use the right language, I might not use the medical technical terms, but what I'm really looking for is access to your brain and your knowledge. Like, something is going on in my body, I don't understand it, and even if I don't use the right words to describe it, what could this thing be in terms of your medical expertise that could be going on in my body? And can we go back and forth on that until we find something that makes sense to me? So that's kind of what I'm looking for. And when we hit that, it feels right to me, and then I stop looking. So anyway.
And that's Sarah, who was on our research team and an incredible contributor to this project. So thank you, Sarah. Thank you. And I'll be around if other people had questions too. Thanks.
Thank you so much. All right, our next presenter is Caden Stockwell. And I'm going to let him share his screen and introduce himself and read the title of his talk. Take it away.
Hello, my name is Caden Stockwell. I am an autistic PhD student in developmental psychology at the University of Virginia, and very excited for the opportunity to speak with you all today. I'm going to share some summaries of some research that I've been working on, and some sort of lessons on inclusion and accessible research design that I've sort of learned with working with other autistic folks over the last 5 years or so. So as you sort of noticed from the title of my talk, Not So Different: Inclusive Research with Autistic College Students and Non-Speaking Autistic Adults, When folks hear that my research sort of focuses on both of these groups, they often say something to the effect of, wow, those are really different groups of people. And my response to that kind of from the beginning has sort of been, well, yes and no. And so what's stood out to me from working with speaking autistic college students and with non-speaking autistic adults and their families, one thing that's sort of become very clear to me is that both are operating in systems that are really not designed with them in mind, both in day-to-day life, in healthcare settings, like we've heard about some today, as well as in specific contexts of participating in research. And when I was growing up as an autistic kid, this was something that I felt, but I didn't really have the words to explain. Growing up, I think back, everyone around me and my cousin Michael, who is non-speaking, tended to focus on pointing out how different we were, and assuming that the kinds of supports that we needed were very different, and had very different expectations for how we would cope with situations or what we would achieve. And this was really different than how I perceived things, which was I perceived myself and Mike to be very similar, from our sensory sensitivities to the need for processing time to the way that we found calm through rocking or through listening to the same song over and over again. And this experience of similarity has really guided my research to sort of understand the experiences of autistic people that many assume are quite different from each other. And some of the research I'll share with you today, over the last couple of years, I've conducted 2 interview studies, one with speaking autistic college students and another with a group of non-speaking autistic adults who, after years of practice, have learned to communicate by pointing to letters on an alphabet board. And these interviews were about different topics because each group of people were interested in different questions. We interviewed the college students broadly about their experiences in college so that we could make recommendations to their university about how to better support them. And we interviewed non-speaking autistic adults about their experiences of regulation and stress and the connection to their social relationships. What I found was really interesting in the experiences that participants in these 2 studies shared with us was sort of evidence of that similarity that I had experienced and noticed when I was growing up. For example, the impact of the sensory environment on someone's ability to process and understand information and on the ability to self-regulate your emotions. Both college students and non-speaking autistic adults noted experiences about the importance of social relationships and how that can help you access support as well as improve your quality of life overall. The impact of anxiety that came from navigating systems that were not designed for autistic people came up repeatedly in both studies, as well as how that anxiety then sort of compounds to make it even harder to navigate these systems. And when we were developing and conducting the interview study with college students, we hired an autistic undergraduate to make sure that the questions we developed and asked were of interest to autistic college students, as well as to make the process of participating in the study more accessible. For the interviews with non-speaking autistic adults, the topic was one that the community we work with in our lab repeatedly said was important to them and that they wanted more research about. So we spoke with speakers and families and supporters when we were sort of developing the study before we conducted it. And what we found was that a lot of what we had done to make interviews more accessible for speaking autistic college students was also what the kinds of sort of changes or accommodations or practices that non-speakers were asking for. So for example, sending interview questions ahead of time, having these questions be informed by autistic community members, both in their topic as well as in how they were phrased. We offered a choice for how participants wanted to do interviews, so in person, over Zoom, or over email. We also conducted these interviews in a lot of different places, since research labs aren't always the most comfortable locations for some folks. We made sure that if a person was doing a live interview in person or over Zoom, we built in more processing time for the interview questions. This was also helpful for me as an autistic researcher who also tends to need more processing time in how I respond to the answers that participants were sharing with us. And in offering and building in times for breaks to participants and building in a way for them to request them if they needed one, but we hadn't asked them in a while. And so as a researcher, this has been really informative to take these insights from different autistic people in these qualitative studies and then use them to inform our more sort of activity-based research, where instead of asking participants questions and reflecting on their own experiences, we might ask them to do an activity to learn, for example, how they process information. And so one question that the non-speaking autistic community that my lab works with has been about literacy skills, which includes knowing how to spell. And so this was a question that they were interested in. And one thing you might sort of ask is if the folks we work with communicate by pointing out to letters and spelling words, doesn't this already show that some non-speaking autistic people have learned to spell? And in our lab, we would say yes. But in all aspects of research, it's really important for us to provide sort of different kinds of evidence of even questions that might seem somewhat obvious. And this was a question that our community partners really wanted us to focus on. And so even with the similarities between the speaking autistic students that we interviewed and our non-speaking autistic participants shared in those interview studies, and sort of the research design practices that we found made it accessible to both groups, these groups do still have different experiences, come from different backgrounds. And when we're moving into more activity-based research, we were thinking it's possible we're still going to have some different approaches here. So for example, with autistic college students, literacy is normally just presumed. Of course, they can spell. And at an activity level, it can be pretty easily sort of assessed with traditional educational or psychological methods. But non-speaking autistic folks are often face assumptions about not being capable of literacy. They might have trouble demonstrating it with different measures for a variety of reasons. And so here it really made the most sense to start working with non-speaking autistic adults and their families and supporters to design an activity that could help us learn more about this sort of community-driven question. And so we worked with non-speaking autistic adults to design an iPad game that would let us examine their reaction time or how fast they were responding. And from this, we could see if their reaction time patterns that the non-speaking autistic adults showed would match what we would expect if somebody had some literacy-related skills. So for example, looking at this iPad on your left here, if we told you, hey, these letters are going to flash one at a time, and they're going to spell out a sentence like, I should water the backyard today. And if you know how to spell, you know that the first letter that's going to flash is I, and then S, and then H, and then O, and so on for the word should. And as soon as you touch each letter, because you know what the sentence is and you know how to spell, you already know where you need to go next. So you're going to be going pretty quickly in this kind of task. And so after we tell participants the sentence, this is a video of I should water the backyard today, the letters flash to spell that out. And non-speaking autistic adults touch those flashing letters pretty quickly. So they go from the I, S, H, O, U, L, D for I should until they continued the entire sentence. We also had participants play rounds of this game where they saw just nonsense symbols here on the right. They flashed in the same order and places as when letters flashed in the sentence, but because these look like random symbols and because of the random order we had participants play these game rounds in, you can't really predict what's coming next. So you're going to be much slower even if you know how to spell. And you can see that here. This person is taking quite a bit longer because they don't know what is going to be flashing next. And so from these data and from some other analyses that I don't have time to get into, what we found was suggestive that most non-speaking autistic adults in our study had acquired this sort of important aspect of literacy. Now, given that the non-speakers we work with point to letters on a board to spell out their thoughts, this wasn't surprising to us, but it's the kind of research that the community wanted, and we were following their lead. We followed their lead in designing an activity that then they were able to go on to use with minimal practice and without prompting from other people. And at sort of an experience level, a lot of participants in this study reported enjoying participating in the activity, which is important to me, that when someone comes into our lab or we go to them, that it's going to be a positive experience and that hopefully it will also be a learning sort of experience. One thing that was sort of interesting in the process of doing this study, and I think kind of a telling interaction we had when writing it up, was one of the scientists who was providing feedback on our research asked us, how did we adapt the iPad activity so that non-speaking autistic people could actually do it? And it was kind of hard for us to answer this question because we didn't really have to adapt it. We started with the community, their needs and their strengths. The activity was designed with them, and we found that this is a task that our non-speaking participants could do. It's a task that speaking autistic college students can also do. And it's also been pretty useful in some other studies that we have going on in the lab to give us additional information beyond the sort of spelling question it was originally designed to address. So by working together with non-speakers, we didn't create a research activity that was just usable for them for this one study. It was also been translational to other research with other groups of people as well. And now a lot of what I've talked about so far has been designing research that's accessible and inclusive for a wide range of autistic participants. But as we've heard earlier today, autistic people really need to play a much larger role in research beyond engaging as participants. And so the mission of the Jaswell Lab at the University of Virginia, where I work, is to conduct meaningful, useful, and interesting autism research inspired and informed by autistic people, their families, and the community. And so we try to do this in a few ways. We bring in autistic undergraduates into our lab as research assistants. Like I've talked about, we partner with non-speaking autistic community members to develop our questions, design our research activities, and also engage in the data analysis. So for example, in analyzing those interview studies that I talked about. And so I think in addition to producing higher quality and more relevant research, this also provides autistic folks with opportunities to develop skills that they can take in becoming the next generation of autistic researchers, but are also transferable to other paths that they might be interested in pursuing. We've been able to use insights from this research to inform things like the sensory aspects of our lab space or how we communicate information with research assistants and participants. This was a paper that came out of our interview study with speaking autistic college students. And one thing that really came out of those interviews was the sort of impact of this mismatch between autistic students' ways of thinking and interacting, and how colleges assume that their students are going to think and interact. And we found a lot of interesting overlap between autistic students' experiences of this mismatch and also experiences of first-generation non-autistic college students, something almost like a mismatch of cultures. And we also found in our interviews with the non-speaking autistic participants sort of descriptions that aligned with this sort of mismatch of system and expectations, even though it might look different in different populations. And with our autistic research assistants and community partners, by collaborating with autistic folks with different experiences and ways of communicating, this has led to the development of more accessible research tasks. And it's also playing a leading role in some of our future work with the University of Calgary in Canada, where we are using augmented reality headsets to investigate if we could provide more independence for non-speaking autistic people who point to letters to communicate, as well as more opportunities for them to make connections and community with other autistic folks. And through this project, we come back to those research practices that we've been learning about with our other studies, that we found in common between speaking autistic students and non-speaking autistic adults to make sure that things like research collaboration meetings and study appointments are more accessible, to making sure that wearing these headsets are as sensory friendly as possible. And and working through interacting with a user interface system that wasn't designed with autistic people in mind. And so in closing, I'll come back to this exchange that I've often had about how different autistic people can seem. What I found is sort of the overarching experience of my research is that we can be more similar than some might initially think. And I think that this perspective can provide researchers with more tools to include non-speaking autistic adults in their studies as participants and as partners. I think it opens the door to learning from each other, both on the research side of things, as well as just in autistic folks' experiences of interacting with other autistic people. And the importance of understanding how similarities and differences can contribute to more accessible support in the lives of autistic folks. And I think it's also helpful even when thinking about the ways in which our experiences do legitimately differ, and that even amidst differing experiences, there are still likely threads of similarity and of connection, and that by looking for similarities amidst apparent differences rather than sort of stopping at pointing out the differences, I think we are going to be more able to work together towards adaptable solutions that really stem from the lived experience of autistic people. So I'll stop there. Thank you for your time. And if we have any time for questions, I'm happy to take them. And I also have my email here if any thoughts come up after the fact, but thank you.
So thank you so much, Caden. It was great hearing about your work. We'll take two questions, one from the room and one from the Zoom. Go ahead, Tiffany. We'll give you the microphone.
Thank you, Caden. My question is, does this have any contact with the controversial practice of spelling to communicate? And did your participants in this study, can you define what you mean by non-speaking? So are these people who primarily choose not to speak, or like developmentally, do they achieve phrasal speech? Or I'm wondering about how you define that. And again, its connection to spelling to communicate, if you see any connection there.
Yes, so non-speaking in sort of the literature is not a very well-defined term. Different studies use different definitions. Some studies use sort of number of words that people are able to say. Our participants that we work with, some of them don't say any words at all. Others have a few phrases or may be able to respond to sort of rote questions like what's your name or similar to that. And so our participants, the groups that we partner with primarily do use spelling to communicate or similar methods of communication. Our sort of perspective on this is a method of communication that is happening and people are using. And so we would like to document various social cognitive effects that may be, or measures that may be using that. So we've used eye tracking to examine how people's gaze precedes their pointing when pointing to letters to spell, for example, as well as some of this recent study, for example, that I talked about with iPads to examine how folks might be demonstrating literacy skills, which we've also, in developing those studies, sort of examined the reaction time patterns of non-autistic college students to examine what the effect would look like there, which we found was very similar, if that answers your question.
Thank you so much for this question, and thank you, Caden. I don't see any questions in the Zoom right now, so we're gonna take a 10-minute break, walk around, talk to the folks in the room, and we'll come back with another presentation from Dr. Philip Smith on complex medical needs. Thank you.
Okay. Thank you for the opportunity to come here and share some of our work with you. And thank you very much for clearly, authentically centering autistic community members and autistic researchers here today and in your work. It is wonderful and refreshing to see. I switched about 2 years ago into autism research from a career in public health. I was diagnosed autistic and ADHD as an adult. My son is autistic. And so that's why I switched fields and am here doing this work now. It's, 3:45 in the afternoon, so I would welcome anybody who feels the need to get up, walk around during my talk. Please do so. If there's anything, my son has taught me many things, but one is that you don't need to be sitting still and looking at somebody to be listening to them and paying attention to what they're saying. So I'm used to doing this with a lot of action in front of me. So you're good to go if you want to get up and walk around a little bit. So I'm going to be talking about autism and children with medical complexity and the overlap and intersection here. This is our research team. Like I said, I'm at the A.J. Drexel Autism Institute at Drexel University. My colleagues, Dr. Diana Schindel, Jessica Rast, Lindsay Shea, are also at the A.J. Drexel Autism Institute. And then Corey is a mom, an advocate, and a community partner in this work. Her child is autistic and has been identified with medical complexity in her state for the purposes of services. And so she's provide invaluable lived experience insights into our work. I do need to say that this work is funded by the National Institutes of Health, partly through Autism Centers of Excellence grant, as well as the Health Resources and Services Administration, HRSA. The funders had no role in, I'm required to say this, the funders had no role in the research or in how I'm presenting it here today. And none of our team has any relevant conflicts of interest to report. So I'll start off with defining children with medical complexity. We've heard about complex care needs, and there's a lot of language in this topic. Children with medical complexity is a specific term, and I'll define it. There are a lot of different definitions and ways of identifying children with medical complexity. It varies from state to state. It varies from clinical practice to clinical practice, and a lot of it depends on the needs or the context for a specific situation. But across ways of identifying these children or defining children with medical complexity, there's some common characteristics. So I'll just run through those really quickly. These are children who often have multiple chronic health conditions that often impact or involve multiple body systems. They could also be children with particularly severe or life-limiting health conditions. These are children who experience a significant level of disability, have functional support needs on a day-to-day basis, particularly high healthcare use, so that could be more office visits, that could be long-term medication use, particularly expensive healthcare, it could be the use of medical technology, and then also a variety of service needs. So this could be across medical specialties, specialty therapies, OT, PT, et cetera, speech therapy, school-based services. So if a child meets all of these sort of criteria, they may be designated as a child with medical complexity. And depending on the definition, just to get a sense of how prevalent children with medical complexity are when we use that specific language and criteria, it's between 1 in 200, which is around 0.5%, or 1 in 50, or around 2% of children. Why am I talking about children with medical complexity? Why focus on this in autism research or more broadly? These are children with particularly high healthcare costs. So despite making up only 0.5% to 2% of the child population, there's been estimates that these children account for up to 30% of US healthcare costs among children. These children tend to have poor short-term and long-term health outcomes. And what we are more and more documenting in research, but what people have been saying for a long, long time, is that there are a lot of unmet healthcare needs, and that a lot of that unmet need is unnecessarily unmet, that there's a lot of room for improvement. So there's been a lot of momentum lately to identify children with medical complexity in the healthcare system, in state services systems. And so there have been efforts across clinical programs, research, and policy initiatives. And these efforts primarily focus on care coordination, improving access to care coordination, health homes, healthcare navigators, and complex care centers, various forms of improving coordination of care. However, the emphasis is on the healthcare system, and supports for these children and their families tend to lack a focus on home and community-based services, and certainly often lack of focus on mental and behavioral health support. Similar to children with medical complexity, autistic children often have multiple conditions, chronic conditions, experience disability in our society on a day-to-day basis, use a high level of health care, and have a variety of service needs. So there's a lot of overlap, is what I'm getting at, potentially. However, efforts to provide supports and services to autistic people, their families, really tend to focus on home and community-based services, especially when we think about Medicaid waivers, et cetera, often lacking a focus on healthcare, and often, again, lacking a focus on mental and behavioral health. So we got interested in the intersection here between autism and medical complexity. We started looking through existing research to see, what's been learned about kids who might be both autistic and medically complex. And when we hit the literature, we saw literally zero research on potential overlap here. And so there's reason to suspect considerable overlap between these groups. What we've already been talking about today is how when autistic people have complex care needs, there are specific needs, support needs, so specific accommodation needs and ways to improve healthcare. And then, as I mentioned, autistic supports and services tend to focus on home and community-based services often, and the opposite is true for children with medical complexity, which really dials in on healthcare. So maybe there's an opportunity for synergy and overlap, or synergy in treating services from a more holistic perspective. So what's being done for this, in this space of potential overlap of children with medical complexity who are also autistic? Virtually nothing to date. There's stuff on the ground that's happening for sure, so I don't want to dismiss or negate any work that's happening from a grassroots perspective. But when you look at policy, services, systems level especially, as well as, like I said, a lot of the efforts that focus on children with medical complexity, autism isn't really part of the conversation. So these initiatives for autism and medical complexity are very siloed, and that includes advocacy efforts as well. So our goals for this research were this is data. So we wanted to estimate the overlap between children with medical complexity and autism in the United States, estimate associated healthcare costs, and characterize across the intersection of these groups health conditions, neurodevelopmental diagnoses, unmet healthcare and service needs, And we also looked a little bit at adverse experiences, including bullying and discrimination. The data that I'm going to share in that topic it's not a major emphasis here, but I do want to acknowledge that those topics can be quite emotionally taxing for some people. So just a heads up that that's coming. This presentation is very light on technical details and methods intentionally, but I do want to just mention that we used our sources of data were two survey data sources. Both are studies that are run by the U.S. government, the U.S. National Survey of Children's Health and U.S. Medical Expenditure Panel Survey. They both rely on parent report, so that's a potential limitation. The Medical Expenditure Panel Survey also does some medical record review, and we're talking about children aged 0 to 17. So these are surveys that are intended to represent the U.S. population, broadly speaking. We used a couple of different ways to identify children with medical complexity in the data based on items that are in the surveys already. And I'll just quickly say that both of the ways that we used have been used both in clinical contexts as well as in other research studies. So this is stuff that's been used before, validated, both in clinical practice and in research. And we use two different definitions to kind of vary the stringency of our definition. And then autistic children were identified in these surveys by parent report of a clinician diagnosis. So again, mostly relying on parent report, which is what was in the data, it's what we had to use, but also a potential limitation. So what we found was higher than we even expected overlap of autism and medical complexity. So just for example, among autistic children, using the less stringent medical complexity definition, 60% of autistic children were also medically complex. That's compared to 2% among non-autistic children. It's a huge difference. Then using the more stringent definition, it was only 17%, but that's compared to only 0.8% among non-autistic children. And so regardless of which definition we used, 1 out of 5 is still a pretty high frequency, and that's using a very stringent definition. And then when we kind of flipped it and we looked at how many children with medical complexity were autistic, so these are children who might be identified as medically complex in healthcare records or insurance claims data or in a clinical context by a provider. Regardless of what definition we use, 41% of children with medical complexity were autistic. So the point here is that our data are suggesting that these two groups, which are treated nearly completely independently in services and practice, there's a lot of overlap there. So then when we went into kind of characterizing health conditions, unmet needs, childhood adversity, I'll start with physical and neurological health conditions. Just to get a sense of the data a little bit for those who might be interested, we're looking at 4 different groups here. So the children who were not autistic and not medically complex, autistic but not medically complex, medically complex but not autistic, and then the children who are both autistic and medically complex. And you can see our numbers for each of those groups. So the first group had 100,000-ish children, around 2,600 autistic children who were not medically complex, almost 900 children who were medically complex but not autistic, and a little over 500 children who were both autistic and medically complex. And we looked across these, we compared these groups based on age, sex, race, ethnicity, poverty status, parental education, and found very little difference in these characteristics between the groups. I'm going to be sharing data, and so before I get into that, I just want to share that I tried to simplify the presentation. So all of the numbers I'm going to be showing are going to be in this format. So there's a bar for not, each of the 4 groups: not autistic, not medically complex, autistic, not medically complex, not autistic, medically complex, and then both autistic and medical complexity. And so I'm going to run through some of these, and I'm sure after I go through a few of them, we'll get the hang of reading these graphs. So we looked at heart, the percent that had a heart condition, autoimmune condition. These are diagnoses that were available in the data. Epilepsy and stomach problems. I'm going to highlight the findings for epilepsy and stomach problems because these are issues that are particularly relevant to the autistic community, and also where we notice some differences. So first, epilepsy, was more highly prevalent among autistic children with medical complexity than the other groups. Also, highly frequent stomach problems, so digestion, constipation, diarrhea. And so these issues that tend to be important to the autism community were highly prevalent in this group of autistic children with medical complexity. We also looked at some mental health and behavioral health challenges, and I'm going to highlight findings for anxiety, depression, and behavioral challenges. So these are parent report. So quite high levels of a parent-reported anxiety diagnosis among children with medical complexity who are also autistic at over 53%. High levels of depression at 1 in 4. And then 80% of parents of autistic children with medical complexity reported behavioral challenges, and I want to present that with a grain of salt because these are parent-reported behavioral challenges, and I'll just, I'm not trying to invalidate that, but also not validate that when some of those behavioral challenges might be, ableist or interpreted, but 80%, quite a bit higher than the other groups. Neurodevelopmental diagnoses. I'm going to highlight intellectual disability, learning disability, and speech disorder. So we looked at intellectual disability, and that was 36% among this group. Percent with a learning disability was 81%, and 76% with a speech disorder. So just summarizing across these health conditions, so autistic children with medical complexity, when both of these things are present, we saw particularly high rates of epilepsy, stomach problems, anxiety, depression, behavioral challenges, intellectual disability, learning disability, and communication differences. So none of this, I would say, is super surprising, but it is, I think, helpful as we're starting to ask who are these kids who might be at the intersection of autism and medical complexity, and what might providers be most likely to see. These are the kinds of conditions that were coming up. Now I'll switch to talking about parent-reported unmet healthcare and service needs. So I'm going to share some data on general unmet healthcare needs, frustration with getting services, and unmet mental health care needs. So across the groups, when children were both autistic and identified as medically complex, their parents reported the greatest rates of unmet healthcare needs, nearly double that of other autistic children and other children with medical complexity. Similarly, about twice as many reported usually or always feeling frustrated and getting in their efforts to get services. And then, not entirely surprising, when parents reported on unmet mental health care needs, they were high across the board. Nobody's getting enough mental health care. Last thing I'm going to share is a little bit of findings in this realm of childhood adversity. So we have parents reporting on frequent bullying, discrimination due to healthcare conditions, and then overall childhood adversity, which in this survey, there were about 10 items that captured 10 different types of adverse experiences that children might have. That includes, these other two, bullying and discrimination due to health conditions, but also discrimination due to sex, gender, race, ethnicity, parental substance use, parental divorce, several different things that a child might go through that are considered adverse experiences. And so parents of children who are both autistic and medically complex reported the highest frequency of frequent bullying. This is bullying at least once per month. Also, most likely to report discrimination based on a health condition, and particularly high levels of, this is 3 or more of these different types of childhood, adverse childhood experiences. Last little piece of data I'm going to present is on total healthcare expenditures. So this is, you can interpret this as annual healthcare expenditures per child in the US. And as you can see here, children who are both autistic and medically complex had substantially higher annual healthcare costs. That's also in comparison to other autistic children and other children with medical complexity who are not autistic, and of course much, much higher than children who don't meet who are not autistic and who are not medically complex. So we're just starting to look into this from a data perspective. And hopefully the data and numbers are a nice complement to the very qualitative, rich qualitative lived experience research that was already presented here today that focused on adults, but of course kids become adults. So overall summary, we found a very high level of overlap between medical complexity autism in the US child population. And there was a lot of overlap across autism and medical complexity groups in terms of health conditions, but when it was autistic children with medical complexity, we had high rates of epilepsy, stomach problems, anxiety, depression, behavioral challenges. And then intellectual disability, learning disability, and communication differences as well. Autistic children with medical complexity had especially high healthcare costs, especially high unmet healthcare needs, and reported very high rates of bullying, discrimination, and childhood adversity, which could loosely be translated into trauma. And so in terms of what we're thinking about future research directions, sorry, I'm realizing I'm running over a bit here. I'm almost done. Lived experience of autistic children with medical complexity and their families is really important. We need to learn more about what these families are experiencing at this age to better understand accommodation needs and what can be done to support these children and their families. It's really important to better understand how families are accessing services and unmet needs across these groups in clinical, community, school, and home settings. And then we're getting some data here. How do these issues of access and unmet needs intersect with other social determinants of health, housing, poverty, historical marginalization, rural geography, just to name a couple of examples. Last slide here. In terms of services and supports, I think there's a clear need for holistic support for children and families, whole body support across healthcare, home, and community settings. Clearly, preaching to the choir here, better access to mental and behavioral health services. We're going to hear more about neuro-inclusive care and the importance of trauma-informed care. And then, of course, do everything we can to address bullying, discrimination, and trauma from childhood adversity and across the lifespan. That's it. Thank you.
Thank you so much, Philip. I wonder if there's a question in the room, and we'll have one question in the Zoom. So I'm going to give the question to Michael here, who hasn't had his chance.
I saw your hand up back there too. I'm more than happy to have a chat too.
So one of the things that I'm thinking of is when you're talking about this sort of issue of medical complexity, and I'm thinking what like an objective definition might be, like scientifically with a person, because I think there's a potential extreme ascertainment bias in terms of how you would define it. So like I'm thinking, for example, like I probably wouldn't have obviously been medically complex as a kid, but if they actually really addressed everything that was developing and happening, I would definitely probably fit a strict criteria for it. And like I think of myself now, the things are more evident. Like, let's say, so I have a diagnosis like hypertension. When I actually look at the literature, I haven't done the literature review, but I would guess I could find 200 chemicals substantially associated with blood pressure regulation in it. It's very complex if you actually try to understand it and try to look for the actual physical interactions involved. And so like most of the medical care system just tries to completely ignore the actual underlying complexity of the things and calls things idiopathic when there's a lot more science there than the medical explanation would give credit to. So I'm just wondering, like, is there some sort of sense of like maybe looking at this sort of proactively going forward and try to sort of think what this would really mean scientifically if we actually evaluated the question properly and exhaustively with people?
So I think you're hitting the nail on the head with a really important challenge, which is trying to do things in a way that meets the complexity of biology, of people and experiences, and also allows for, within our system, the ability to, adapt services to groups of people and from policy and services perspective. And so there's always going to be that tension, I think, whenever we impose definitions, group people into one or two or three or four or five groups. We know that's true with autism, of course, when we treat autism as a binary variable, like just you're autistic or not autistic, like that doesn't actually represent the complexity of what autism is. And so I think that's just something for me to really think about, Michael. I appreciate your comment in terms of thinking about moving this work forward in a way that doesn't oversimplify what it means to be complex and exclude people who might have complex needs. So I appreciate your comment, and I'll be thinking about that. It's a great comment.
Thank you. And I don't see any question in the chat, so did you want to ask your question? And I will go straight to Dr. Hauser.
My question was just about in the study, how gender balanced was the study, and to what extent do you notice the difference of rates of diagnosis between different genders still impacting research and services and all of that?
So it's a great question. And first thing I'll say is we haven't taken that dive as deeply as we'd like, not just based on sex, gender identity, but also other groups. What was interesting from what we've done so far is the gender breakdown is what you would expect in terms of people who are, identified in the data as autistic being more heavily male. And that difference isn't the case when you're looking at children with medical complexity. It's more balanced. But some of the, I'm gonna use the word sex differences to try to, be specific here, that we see in health condition diagnoses, mental health, physical health, for example, depression in the general population, didn't show up in this, it shows up in the population in non-autistic, non-medically complex, but not so much in the autism medically complex group. The sex difference in the rates of diagnoses, for whatever reason, are more balanced out. But like I said, we haven't taken a deep dive into that. It's a really important question, and it's on our list of things to really get into. So thank you.
Thank you so much. And we're going to, I think, continue that discussion hearing from Dr. Melhauser. So thank you, Philip. Mel, we're going to have Emily introduce you, and then we'll be able to share your screen.
All right, we have one final talk from Dr. Melhauser, who's going to share her screen. I'll let her give a little bit of her background and the title of her talk. Mel, you good to go?
Yeah, we see your slide, Mel. You're good to go.
Great, thanks so much. Actually, before I start, since I have a quick video clip at the end, I should learn better to click the share sound button before we start. Okay, perfect. So hello, everybody. I'm Melhauser. I use she, they pronouns. I am the executive director of All Brains Belong Vermont. We're a nonprofit in Montpelier supporting people with all types of brains. And I'll tell you more about that as we go. We're going to be talking about neuro-inclusive healthcare. The framework I'd like to just introduce is that one size fits all does not work for all. And so many people struggle to access a lot of things. So autistic and otherwise neurodivergent people are more likely to struggle to access all kinds of critical resources: healthcare, education, employment, social connection. And neurodivergent people often, and we've heard from several speakers already today, often feel alone and broken. We know that's not true. As it relates to social isolation and loneliness cause equivalent harm to health as smoking 15 cigarettes per day. And what we know is that neurodivergent kids and adults experience high rates of this. And so when we think about all of the other systems that are not meant and not designed for people with all types of brains, it's also not surprising that things like autistic adults being 2.5 to 8 times more likely to be unemployed or underemployed. 75% of ADHDers experience employment-related challenges. And we know that employment and health are bidirectionally related. What we don't want is we don't want the square peg being hammered to fit into the round hole, because what happens? You break the peg, and so many people are being shoved into containers that don't work for them. As it relates to healthcare, we know that there are extensive barriers to accessing healthcare. So from these 3 studies, looking at the healthcare experiences of autistic adults, first off, 80% of autistic adults struggle to access primary care amongst people who have primary care practices. Like, it's not, oh, I got to find a practice who's accepting new patients. It's, I have that and I still can't access. Not surprisingly, nearly 70% of autistic adults have untreated health conditions. And the barriers to accessing that care cluster around these 3 buckets: the environment or interactions with the environment, the provider, autistic adults in these studies perceiving that their healthcare providers have insufficient knowledge and skills and unhelpful attitudes to provide care to them, and the system There are so many defaults in the healthcare system, so many defaults that are a mismatch for patients' needs. You know, you must pick up the phone to make an appointment. You must, you know, fill out the 20-page packet to become a new patient. And anytime there is a default, one way of doing the thing, anyone who does the thing differently is going to be othered. There's also a problematic culture, and you heard about this from Dr. Lewis, the perception of patients that their healthcare providers are viewing them through an unhelpful lens. And I can tell you, as a physician who was trained in a traditional setting, there really is a hidden curriculum for medical trainees. You know, you are taught. Sometimes it's not even hidden. Sometimes we're like literally taught explicitly that there is one correct way to develop in this linear hierarchy that progresses. We are taught that there's one way to that this medical condition presents. There's one way to look when you're in pain. All of this contributes to systemic barriers to healthcare access. But that's not why we're talking about this. We're talking about this because autistic and ADHD adults are dying. You heard this statistic from Dr. Lewis a little while ago, that autistic adults have an average life expectancy of 36 to 54 years, with leading causes as cardiovascular disease and suicide, with autistic adults having 4 to 9 times increased higher rates of suicide. ADHD adults, 4 times increased risk of premature death. When I learned this, it was a few weeks after I received my own autism diagnosis. I was then the parent of I still am the parent of an autistic child, but at that time, this child was 4 years old. I'm the parent of a 4-year-old who just got my autism diagnosis and learned that the average life expectancy is 36 to 54, and I was 37. This was a hard stop. How did people not know this? Why was nobody talking about this? Why was anybody not doing anything about this? I was a doctor who already at that time was mostly taking care of autistic patients, and I didn't know about that, let alone the rest of the healthcare community. And so that was the impetus to start All Brains Belong. So we're a toddler nonprofit, just over 2 years old, that has developed a novel model for healthcare delivery, where we integrate medical care into social connection, community education, employment support, with the idea that healthcare is more than medical care. Even before all this, I was noting that my experiences trying to support my patients with their health, we were spending all our time in the exam room problem solving life outside the exam room. And I showed you all that data, and that's what I was seeing. People were lonely, struggling to make friends, struggling to access their education, struggling to access employment. This is all part of health. And what we like to say here, that to do anything, we must do everything. So our programs cluster into these 4 buckets. So who does ABB serve? All Brains Belong serves neurodivergent kids and adults, also community members seeking education and social connection, professionals and organizations seeking to learn more about neurodiversity and inclusion. So I'd like to say that All Brains Belong's work impacts everyone. Really, over the past 2 years, it has been the coming together of people whose needs were not met by the traditional system. People who, like Dr. Lewis shared in this recent research study, these were people whose lived experience was to be invalidated, dismissed, to really be thwarted, not just by the healthcare system, but all the broken systems. So people coming together and reimagining, not just healthcare, but reimagining everything. And it's been a process of co-creating as a community health village, co-creating a different way. With the idea that when you bring people together so that they feel listened to and valued, being able to show up as their true selves and feel connected to community, that this itself is health promoting. All of our programs have been developed in collaboration with our patients. Really, this is, as I mentioned, a co-created process with the people that we're serving. So right from the very beginning, before we launched, we asked our community, what does inclusion mean to you? And this is what informed our initial programs. Let me tell you about our programs. So as I mentioned, we have these 4 buckets of programs. In the healthcare space, this, as I said, a new model of care that's very different than traditional practice because patients are coming to meet other patients. They're participating in community groups, participating in a community village. We provide medical care to toddlers through older adults. And the whole idea is one size fits all does not work for all. So what could healthcare look like as a customized, individualized healthcare experience? We provide medical care to neurodivergent kids and adults, and both primary care and people who are coming for support for medical conditions more common in neurodivergent patients. You heard a little bit about this from Dr. Lewis, and I'm going to speak more about some of the medical conditions that are more common. What we find at our practice, again, a self-selected group of people, not everyone is neurodivergent, but what they have in common is that their needs were not met by the traditional healthcare system. And in fact, of our autistic and ADHD adult patients, 97% suffer from a constellation of intertwined medical problems involving the nervous system, sleep, connective tissue, the gastrointestinal system, the immune system, the cardiovascular system. This is a constellation of intertwined medical problems. And unfortunately, because of the barriers imposed by the traditional healthcare system, clinicians really are thwarted from being able to zoom out far enough to see a patient's interconnected systems as a unified whole. And you heard about this from Dr. Lewis. And what ends up happening, just as the participants in the study that you heard about, what happens is that people have this of intertwined medical problems, but the healthcare system that really fragments the body parts and interferes with clinicians being able to address more than 1 or maybe 2 problems at a time in a 10-minute appointment, that really interferes with many people not getting better. And as one of my patients said, oh, it's like a ball of yarn, where if you pull the wrong string, you make the knot tighter. You have to find the right string to pull. And yes, that's what it's like. Because in fact, sometimes the standard medical management of some parts of this constellation actually make the other parts worse. So for example, if someone has chronic pain and they are prescribed a muscle relaxant, but in fact, they have a connective tissue disorder where their connective tissue is floppier or stretchier. Now, in fact, the muscle relaxant made the connective tissue floppier and stretchier, including in the airway, where their undiagnosed obstructive sleep apnea is now worse, which now makes their dysautonomia, their autonomic nervous system problems worse, which actually makes their pain worse. And that's how we all started. And now we've got even more problems than we started. So I'm very proud to share this resource that was created with support from the Organization for Autism Research and by HRSA through the Autism Intervention Research Network for Physical Health grant. So this is a completely free resource. I'll put the link in the chat. A free resource that the goal is to empower patients to be able to work through these medical problems with their clinicians. It's really about bridging the double empathy problem that you also heard about earlier. Double empathy problem, of course, being, if you missed Dr. Lewis's talk, the double empathy problem is a term coined by Dr. Damien Milton, who was an autistic social scientist in the UK. The double empathy problem states that when there is a mismatch of neurotype, a mismatch of worldview and communication style, that's where breakdowns happen. And gosh, there is a double empathy problem between patients and clinicians for sure. So I'm going to put this link in the chat. So part of this resource are patient education materials offered with universal design principles. There are videos, there are graphics, there are text, There's also a tool where patients can print out a letter that is written in the language that primary care physicians are used to receiving information, that introduces the primary care clinician to the clinician guide. There is a 16-page comprehensive clinician guide that walks through how not only do we approach these medical problems, but actually the literature supports the approach of these problems together. So it's a 16-page evidence-based clinician guide, all freely available on this website. So what else do we do here? We provide healthcare in a non-traditional setting. So many of our patients, again, who've had significant negative experiences with healthcare, and including experience a lot of healthcare trauma. When what we know is that trauma lives in the body, and so you walk into the healthcare environment with the fluorescent lights, and it's not just the fluorescent lights bothering you now, it's the memory of the traumatic encounter that you had in the last environment that looked like this place. That is a barrier to healthcare access also. So we very intentionally design our environment to not be like that. It does not look and feel like a healthcare setting at all. If you want to know more about the specifics, and we only have I think I have to wrap up in the next couple of minutes. So if you want to learn more about what we do here, we have a free webinar that we're doing this Tuesday. Actually, I'll put the link in the chat. Where it's our hope that we'll continue to bridge the double empathy problem, where clinicians can come and learn specific ways of adapting healthcare delivery to be inclusive and meet the needs of people with all types of brains. It's also a place where patients can come and get ideas about what they can ask for in the settings where they are accessing healthcare. But beyond healthcare, we have a number of free community programs that are open to everyone, even people who don't get their healthcare here. So for kids, I guess actually I have the slides differently. So for adults, we have a program called Brain Club. It's a weekly community education program where we cover a range of topics relating to neurodiversity and All Brains Belong's approach to neuro-inclusive culture. I'll put links in the chat when I'm all done with the slides. For kids and teens, we have a program called Kid Connections, or Kid and Teen Connections, because sometimes teens don't like seeing a program that's just called Kid Connections. So open to kids 3 to 17, where this is a customized friend matching program, open to anyone located anywhere. We have people participate from across the country, even in other countries. It's that kids and teens or their support folks or caregivers fill out a profile about these are the things I love. This is how I communicate. These are the things that stress me out. These are the things that are comforting to me. And then we make a customized friend match so that everyone can have a friend who loves what they love. The best part of this program is that it was conceived of by a child. It was conceived of by a then 9-year-old on our junior advisory board. When I asked him, how do we help kids feel like they can belong? Without any hesitation, the sweet little love says, you let us do what we love. So sometimes people call All Brains Belong and they say, do you do social skills programs? No, we do not do social skills programs. We bring people together based on shared interests. We're also bringing the community together this summer for our 3rd annual Community Health Education Fair on the State House lawn. I'll put a link in the chat for folks who want to sign up for our monthly newsletter, and we'll have more information coming out about this. But this is something that we do every year. It's about breaking down silos, bringing together community resources from around the state. It's a way of demonstrating that there's no right way to participate. This is part of healthcare. We also provide trainings to a range of different types of organizations about how to improve their neuro-inclusivity. And this educational training is all through the lens of enhancing access. Access needs being anything that anyone needs for full and meaningful participation. Everyone with all types of brains has access needs. And a few years ago, our community advisory board told us that when we asked, how can we tell that our community has become more neuro-inclusive? Look how often people talked about access needs, just making this be part of the everyday vocabulary of this community. We also have employment support programs for our patients. We also have a community neuro-inclusive employer bright spotting program that recognizes Vermont employers who are creating workplace environments where people with all types of brains can get their needs met and thrive. And I'll wrap up with a short video clip.
Meet others in the community who are going through the same or similar things, which then gives us the opportunity to learn from each other's experiences and to really value and feel valued by each other and feel a lot less alone and a lot more hopeful. And so it ends up feeling like a community more than a medical practice.
What I often see is once people feel safe and once people have been cued safety, they're able to engage in community. And that's when we really see these kind of healthcare jumps for people. We see, people come to group visits and learn from other people and have that shame reduction of, oh, it's not just me dealing with all these things. There's other people who believe me, there's other people who are like me, and get really quality medical care too.
To be in a community where I get to explore and learn about my brain and other people and other people's brains.
We're all in this together as individuals that, that sees things differently, hears things differently, moves things differently.
Smoothing out the rough edges of my experiences and of my perceptions. I'm less harsh on myself. I'm less sharp with myself.
Right? It's exposing me to people being so beautifully raw and authentic because the space allows that. And I can't think of many spaces in life that allow for people to come together in this way and kind of like this radical act of trust.
ABB to me has been a way to have community, have social connections, to understand my body, to reframe mental illness into, autism, to medicines that, simple medicines that have been able to make my mobility and my ability to be in the world different. ABB has given me a way to be myself and in community with others that I hadn't had in so long.
What do you mean healthcare can be like this? So with that, we'd love for you to get connected to any of our programs. I'm going to put a link in the chat that has a link to all of our programs and the mail and the newsletter and all the things all in one place. And with that, I'm happy to take your questions.
Thank you so much, Mel. So again, we'll go and take about 2 questions between the room and Zoom, and then we'll be closing this long day of very interesting and thoughtful, research information. So anybody in the room has questions for Mel? And now they know how to reach you too, Mel.
Hi, Mel, this is Patty. Thank you again for all the amazing work you're doing. Are you still open for patients? Or I know you've had a lot of people lining up, and I just have an adult that I have connected with, and before I make a recommendation, although she does know about All Brains Belong, but are you still taking patients?
Well, thank you for the question. Unfortunately, we are still completely saturated. The need is just so great. For medical care, that's exactly why we're doing this webinar on Tuesday, because we know there are so many more people who need something different for their healthcare than we are able to serve directly. So again, right now we're close to new patients and our waiting list is also full. The best way to find out when we reopen the waiting list, which I'm hoping that we're able to do by the end of the year, is to sign up for the newsletter. But in the meantime, we would love the person in your life to be able to connect with Brain Club and our free community programs.
Thank you so much. I was really appreciative to hear about your brain club and the community program. So I think that will be my first step. Thank you.
Awesome. Thank you.
And we have another question for you here, Mel.
Thank you for your presentation. You do trainings for companies that want to really learn how to embrace the neurodiverse population. I'm the parent of a 27-year-old Burlington adult on the autism spectrum. Are there any linkages between the trainings that you do and employment opportunities? Any connections that you make from the companies that you've trained?
Really great question. I would say that right now, I mean, we're very new as a small nonprofit, so we haven't had the experience of like bridging any of our patients to work for the organizations that we've done trainings for. We do support our patients in accessing employment, but as of right now, those processes have been separated. That there's folks who've come for trainings and folks who need help accessing employment.
As job coaches and case managers, that the normal support mechanisms are, they're losing people that organizations taking on thanks to your training. To be able to commit to take on and support as job coaches almost within their organizations, it would fill a need. But I know you're doing everything.
Thank you so much, and I absolutely agree with you. I think that we've been encouraged by Higher Ability Vermont really working very hard to learn about the needs of neurodivergent folks that they are working with. And so I'm very optimistic that Higher Ability as a support resource in the community are improving their capacity to serve this community. The other thing that I would mention that I think is really important that your comment reminded me of is that neuro-inclusion benefits everyone. It's not a set of practices or things you do extra or special for a group of people. It's about how you create environments for people with all types of brains, because often employers don't know what someone's access needs are. Often people don't know what their access needs are. And so there's that. And then I think also from the employer's perspective, I say this as a neurodivergent employer of neurodivergent people. There's a lot of learning how to negotiate conflicting access needs is a really important framework, and it benefits everyone. And so for employers who are spending a ton of time and resources and money with turnover, guess what? When people have their needs met, they're less likely to quit their jobs. And so that's one of the reasons that we talk about neuro-inclusion really benefiting everyone.
Thank you very much. That's absolutely spot on. They do make organizations better.
Thank you.
Thank you, Melissa. It was perfect closing of this day that we had of research discussion and all. I want to thank you all for joining us. I know it was a lot to process. You have the posters and the PDF and the mailings that you received. If you registered, I will send you a link to the recording for today. And also, you'll already have received a link to a feedback survey that we sent you. So I want to thank my team, which is a pretty large team, but Dr. Emily Coder has been really instrumental with everything like budget, organization, room reservation for this event, but also PCORI projects. Dr. Patricia Prelock, I learned one thing in life is never try to do something if you don't have administrative support. And we are grateful to have administrative support, the support of UVM for the work of the Autism Collaborative. So thank you very much, Dr. Prelock. You heard today of Dr. Laura Lewis. who is spearheading, research with community partners, so embodying this very hard ideal. So thank you for all your work, Laura. Thank you to our guest speaker, Dr. Philip Smith, or PhD candidate, I believe, Caden Stockwell has joined us today. The whole Autism Collaborative, Zeph, who's been managing our Zoom. Thank you for technology here. Sorry for our Zoom attendees for our computer here crashed, which caused some hardship on your side. So we apologize for that. Yeah. Jen, thank you for sharing and coming despite all that was going on in your day today. Michael, very grateful that you were able to make the trip from St. Johnsbury. So without further ado, please have a wonderful rest of your day. Take time to look at the posters online or in person, and we'll hope to meet again at least next year, right? If not every month on Zoom and for a variety of projects. Thank you, everybody.